postprandial phlegmatism, when everybody goes to sleep. So maybe we should go ahead and get started. So we're going to begin now with ventricular septal defects. And this is defined by our surgical colleagues in their magnum opus on various definitions as a hole or an opening in the interventricular septum. So that's what we're talking about. And there are a number of associations with this. Of course, a number of trisomies, trisomy 13, 18, and 21 are all associated with ventricular septal defects. There are a number of genes that are associated also with VSDs, mutations thereof. Interestingly, TBX5, GATA factors, and NKX25, which are the same ones we talked about before for atrial septal defects, can also be associated with ventricular septal defects. Some patients with Holt-Oram syndrome have VSDs or even hypoplastic left heart syndrome. And then TBX3 has recently been, ulnar mammary syndrome has fairly, in the last 2 or 3 years, been associated with ventricular septal defects. And another factor, Sal-like 4. Sal-like 4 is a cofactor of TBX5 and GATA, works with them probably in development of normal atria and ventricles, and also the conduction system. And Sal-like 4 has been associated with VSDs also. And then, of course, we know the DeGeorge phenotype, the DeGeorge syndrome, which is primarily due to a TBX1 mutation for the cardiac parts of it. There are a lot of genes that are missing in the 22q11 deletion, but the cardiac part seems to be mostly related to TBX1 mutations. And that produces the kinds of defects that we see in tetralogy of Fallot or truncus or interrupted aortic arch, where the outlet septum is not aligned properly with the rest of the ventricular septum. And also CHARGE syndrome, the CHD7 gene, which is responsible for about 70 or 80% of CHARGE syndrome, is associated with a similar DeGeorge type phenotype, or at least it can be. And so ventricular septal defects, as we said, are communications, one or more here at ventricular level. This is associated typically in most patients with an isolated VSD with left to right shunting at ventricular level. The size of the defect largely determines the amount of the left to right shunt. Smaller defects may have insignificant shunts. Big defects may have very large shunts. If there are problems with the right ventricular outflow tract, then of course the shunt may go right to left. And this produces primarily a left ventricular volume overload, although large defects produce a biventricular volume overload, and variable pulmonary hypertension depending on the size of the defect, the shunt, and the duration largely. So we can, if we look at the interventricular septum here, we can figure out where defects are usually located in the ventricular septum. Here we're looking at the inlet or body of the right ventricle. Here you can see the papillary muscle of the conus up here. This is the septal band here coming down the septum. The moderator band would be coming out like this. And this is the posterior papillary muscle. The anterior papillary muscle is up here where we don't actually see it. But this is the commissure here between the anterior leaflet and the septal leaflets of the tricuspid valve. Is there any way to, let's see, is that difficult to see at all? Maybe if we turn off the overheads, that would help also, although I think most of it is coming in back here. But anyway, the commissure here is where the membranous septum is located. Just behind this commissure is the location of the membranous septum, and that's where we would see smaller membranous defects. Yeah, that's better. Membranous defects can extend down into the muscular septum, down into the inlet septum here, behind the septal leaflet of tricuspid valve, or even up toward the outlet, although they usually don't get too much above that. Then on the other side, we can look at the outlet of the right ventricle. Here's the pulmonary valve up here. This is the parietal band, infundibular septum, moderator band complex here that forms the supraventricular crest. Here's the papillary muscle of the conus, which marks the inferior ramus of septal band, and this is superior ramus up here, and the conal or infundibular septum fits into it to close the old interventricular foramen during development. And so outlet defects are in this part of the right ventricle. Malalignment of the infundibular septum here with respect to the rest of the septum occurs in things like tetralogy of Fallot or double outlet right ventricle or interrupted aortic arch. Absence of this part of the infundibular septum or conal septum produces subpulmonary or doubly committed subarterial or conal septal defects. There are a number of names for these things, but basically what it does is leaves the semilunar valves unsupported by any muscle, or at least one or two leaflets unsupported by muscle, and allows aortic valve prolapse. So that's another type of defect. And then muscular defects can be sort of down anywhere in the anterior muscular septum up here, mid-muscular septum toward the apex, or down on the diaphragmatic wall. And we usually try to identify them both in their anterior or superior inferior position this way with the diaphragmatic wall here and the outflow of the heart up here. And so we would want to know where they are in this axis as well as where they are in an apex to base dimension so that the surgeon can easily find them. From the left ventricular side, here we see the left ventricular septal surface here. This is the right coronary leaflet with the right coronary ostium there, the non-coronary leaflet here, and the membranous septum from this side is just below the commissure between the right and non-coronary leaflets of the aortic valve. So in a short axis view, you can use this as an indicator of where the membranous septum is, just like in a short axis view of the right ventricle, you can use where the commissure between the septal and anterior leaflets of the tricuspid valve is to locate the membranous septum. And then you can figure out from there the inlet septum is going to be in this direction and the outlet septum is going to be in this direction. Okay? And you can see here that it's the non-coronary leaflet that's mostly in continuity with the mitral valve, the non and left, the right is not. And the membranous septum, which you can actually see well in this heart, is just below the commissure between the right and non-coronary leaflets. So here's an example of what we would call an inlet muscular or AV canal type defect. It's here we're looking in the right ventricle. This is the tricuspid annulus here. The apex is down here. And this is all the septal leaflet of the tricuspid valve here. And the defect is all behind the septal leaflet of the tricuspid valve, extends all the way up to the papillary muscle of the conus here, up to the beginning of the outlet septum. And then it extends inferiorly down to there's the papillary muscle of the conus, and the septal band there, and that's the outlet septum up there. So that part is, and there's pulmonary valve further up. That part is all intact. This defect is here, completely below and behind the septal leaflet of the tricuspid valve. Now we're looking from the left side. This is the posteromedial papillary muscle group. And here you see the tricuspid valve through the defect and the mitral valve here. And this is the continuity, the fibrous continuity between the mitral and tricuspid valves. So you can see this is a very large defect. It extends all the way to the annulus of the AV valves, and it extends down to generally close to the diaphragmatic wall of the heart. So this is a big inlet muscular defect, or what is often called an AV canal type defect. And notice that in this case, here's the right, sorry, this is the right coronary leaflet. So this extends well below that. So here's another membranous type of defect that's a little bit confined to a little bit more can't get back to it. Here we go. So this is confined to the membranous septum. It's up As I said, at the commissure here between the septal leaflet, which you see there, and there's the defect right there. Here's the septal leaflet of the tricuspid valve, and the anterior leaflet is this leaflet up here, that one. So there's the defect just below that. And here we see the pulmonary valve and right ventricular outflow. The outlet septum and all of the outflow is completely intact. Here's the papillary muscle of the conus, which marks the junction of the inlet and outlet of the ventricle. And you can see this on echo, by the way. And here's the defect just under the septal leaflet of the tricuspid valve there. And here from the left side, here you see the defect here. This is the right and non-coronary leaflets of the aortic valve. Here's the defect, a little extra piece of tissue there. And you can see that it's below this commissure between the right and non-coronary leaflets. So this is a typical location. Extends up a little bit toward the outlet because it goes well up under the right coronary leaflet here. Here's another membranous defect. And here you can see this is a little bit larger. Here you see the defect here. It does extend up above the papillary muscle of the conus, so it extends up into the outlet, and it extends back here behind this part of the septal leaflet of the tricuspid valve. And here from the left ventricular aspect, you see the tricuspid valve through it because it's covered partially by tricuspid valve. And here's the typical muscular rim of the inferior part of this up here. And here's the right and non-coronary leaflets of the aortic valve, the commissure in between. And so the defect is really right below that and extends up a little bit and toward the outlet septum. And this one extends back a little bit inferiorly toward the inlet septum. And here you have the, again, fibrous continuity between the tricuspid valve here in the right ventricle there and the mitral valve over here in the left ventricle, forming the floor of the defect. The conduction system in this type of defect, of course, runs inferiorly down here on the inferior rim, right on the muscle just under the mitral tricuspid continuity across here, and then ramifies over here in the left ventricular side. This is a similar defect, but with a subaortic membrane. Here you see the defect again from the right ventricular aspect. Here again is the papillary muscle of the conus. Here's the septal leaflet of tricuspid valve. This is the anterior leaflet up here. There's a big commissure between them right here, and that's exactly where this defect is. Now, in this case, when we turn this over on the left side, this is still looking up at the outlet septum. Here's the infundibular septum here, parietal band coming around over here, and the pulmonary valve up here. So all of this is completely intact. This is again below the papillary muscle of the conus. Here we see the non and right coronary leaflets. There's the right coronary ostium there in that leaflet, or in that sinus rather. And here's the defect right here below this commissure. You can see it come right below the commissure there. There's still a little bit of the fibrous trigone left here. And then we come down and there's the defect here. Again, you see the tricuspid valve through it because the tricuspid valve is covering it on the right ventricular side. And this is what can form an aneurysm to partially close membranous ventricular septal defects. In this case, notice that there's a little fibrous ridge here on the apical edge of the ventricular septal defect. This is the beginning of subaortic stenosis, which occurs in maybe 5 or 10% of patients with large membranous ventricular septal defects. So this is what the little membranes look like on the crest of the septum that can develop into subaortic stenosis. And in a membranous type of defect, where the outlet septum is where it should be, this ridge is on the apical side of the defect, on the ventricular side of the defect, whereas when there's outlet septum malalignment, the outlet septum is over on the aortic valve side of things, causing subaortic stenosis there. This is a conoventricular defect, or a defect between the conal or infundibular septum above up here, this, and the muscular septum below. This is the Y of septal band. This is the septal band's body here. Superior ramus up here, inferior ramus here. Here's the papillary muscle of the conus. So this defect is completely above in the outlet part of the right ventricle. And the infundibular septum is here. It's out of alignment with the ventricular septum, and in fact, it's back here above the left ventricle. In this case, this is a posterior malalignment defect that narrows the left ventricular outflow tract and causes subaortic stenosis. So this is sort of the opposite of tetralogy of Fallot that we'll talk about a little bit later on. Here's the defect, but this is the left ventricular outflow tract back here. The aortic valve becomes small because the outlet septum is deviated posteriorly, encroaching on the left ventricular outflow tract and causing subaortic stenosis. As I say, this is the type of defect that we usually associate with interruption of the aortic arch, probably because it reduces blood flow across the left ventricular outflow tract. And this is a defect of the conal septum or infundibular septum, a conal septal defect or subpulmonary defect or doubly committed subarterial defect. There's the septal leaflet, anterior leaflet of the tricuspid valve down here. And you can see the inferior leaflet is down here on the bottom. So this is all of the tricuspid valve. This defect, again, is completely above, up in the outlet part of the ventricular septum. This is the Y of septal band here, the inferior ramus marked by the papillary muscle of the conus, superior ramus over here. And if we look closely, you see there's aortic valve leaflet on the other side, right there that we're moving. Here's the pulmonary valve leaflet up here. And there's no muscle between the aortic valve leaflet and the pulmonary valve leaflet here. So this is absence of the outlet septum or infundibular septum. That's what a subpulmonary defect is. From the left ventricular side, here we see now this is the right coronary leaflet here. We just had the probe in the right coronary ostium. So this is anterior to that or below that. So it's not back in the membranous septum back here, which would be below the right coronary leaflet back in this area. So this is a different kind of defect. This is clearly an outlet defect, and it allows prolapse mostly of the right coronary leaflet of the aortic valve through the defect and into the right ventricular side and causes aortic insufficiency. And finally, just a quick look at a couple of muscular defects here. This is looking again from the right ventricular side, and in this case, here you can see there's a big muscular defect down here completely below the outlet septum and partly behind the tricuspid valve. And there's a muscular ridge up here now between the defect and the AV valve annulus. The pulmonary outflow tract is up here. This is infundibular septum, parietal band, septal band over here. And if we look from the left ventricular side, again, you see this defect, but you see that there's muscle all the way around it. It doesn't go to the continuity between the mitral and tricuspid valves. There's muscle around the defect. This is just another example of a muscular defect here. A little bit further down in the septum, this is a mid-muscular defect. You can see the septal leaflet of the tricuspid valve here, and this defect is just slightly apical of the free edge of the tricuspid valve. So this is mid to apical type of defect, and here we can see it from the left side. You can see it's at the junction between the smooth part of the muscular septum here and the finely trabecular part of the apical muscular ventricular septum. There are often little fibers. These may be conduction fibers that cross these types of ventricular septal defects on their way to the papillary muscles. This one's been divided here. So management of these, typically ventricular septal defects are attempted to be managed medically because a fairly large number of them will close spontaneously. So it's useful to try to manage these medically if a child is in congestive heart failure or a baby is in heart failure, to try to allow the defect to close. Diuretics are clearly part of this. whether vasodilators or digoxin are part of this is a bit questionable. Then surgical closure for babies who are failing to thrive, have significant pulmonary hypertension, or have persistent left ventricular dilation, evidence of end organ effect of the ventricular septal defect. And some of these, particularly muscular ones, seem to be amenable to device closure. There's been also closure of membranous defects, but there are some complications with that, and it isn't clear to me at this point that that's really a terribly good option for membranous defects, which can be closed really quite well surgically. So we'll stop at that point, and I think Dr. Rudolph is up next.
There. Go back one is there. Well, my first slide is to just show you what I showed you earlier today, and it reiterates what I said about the cardiac output in the human fetus. And again, what I want to point out to you is that the left ventricle ejects about 45% of the combined output, and the right ventricle about 55%. The pressures in the right and left ventricles and in the pulmonary artery in the aorta are pretty much the same. They're identical in the fetus. So that what this means, if you take that information together, is that the two ventricles are very similar in their functioning, but that the left ventricle is facing a somewhat higher afterload than the right, because it's ejecting a little less at the same pressure. In the human, the pulmonary vascular resistance is lower than umbilical vascular resistance. In the sheep, it's much higher. But because of this arrangement with the ventricles, what one would expect, because the afterload on the left ventricle is slightly higher than on the right, that during systole, there will be a small left to right shunt in the fetus, going towards a somewhat lower resistance. And in fact, it's really remarkable how few studies there are that have been reported on shunting through ventricular septal defects in the fetus. But in the few studies that have been reported, what they have shown essentially is what one might expect, and that is that there is predominantly left to right shunting of small degree during systole. And the other thing that has been seen is a small right to left shunt during diastole, or in one study, the last one here, at the end of systole. Now, the question one might ask, here you see the study by Lethal, in which there was bidirectional shunting, both in systole and a little at the end of systole. Now, the question is, why is there the right to left diastolic shunt? And the reason for that is almost certainly related to the fact that because the left ventricle ejects into the right ventricle through the VSD during systole, that it has a smaller volume towards the end of systole and early diastole, and therefore there is some small right-to-left shunt at that time. But it's not a significant amount of shunting that occurs. And almost certainly it has a minimal effect on either the oxygen saturations in the fetal circulation or on pressures. Now, what happens after birth? Well, again, the main factors that influence the postnatal circulation are the size of the defect, obviously, and secondly, the changes in afterload on the two ventricles. And after birth, the systemic circulation, because of the loss of the umbilical placental circulation, develops a somewhat higher afterload. Resistance increases. Whereas because of the pulmonary vasodilatation after birth, the afterload on the right ventricle dramatically decreases. Now, the initial fall of pulmonary vascular resistance is extremely rapid. So with the onset of ventilation and oxygenation of the lungs, that pulmonary vascular resistance drops by about 8-fold within the first few minutes after birth. Extremely rapid. So that one would get some left to right shunting almost immediately after birth. Now, what happens subsequently, so that is this initial fall here from the pre-birth to after birth. Then after that, there's a further reduction related to the change in the pulmonary vessels. In the fetus, the pulmonary vessels all have very thick walls, especially the vessels of about 50 micron diameter, which you could call arteriolar level. They have very thick muscular walls, and after birth, these vessels gradually undergo thinning, and associated with that thinning of the 50 micron vessels, there is a further fall in pulmonary vascular resistance, and nowhere nearly as dramatic as the immediate fall at birth. So that associated with this further fall, there's a progressive increase in the left to right shunt. Now, if one changes pulmonary vascular resistance, increases pulmonary vascular resistance, for example, if the baby gets lung disease, then that will certainly increase pulmonary vascular resistance and limit the left to right shunt. And in fact, if the pulmonary vascular resistance is increased enough, you will now get right to left shunt. So what happens in infants with the VSD? In the immediate postnatal period, with a large ventricular septal defect, the pressures in the two ventricles are equal. The pressures in the pulmonary artery and aorta are pretty much equal, and you get a modest left to right shunt here. So that you see the oxygen saturation of aortic blood is about 98%, and of pulmonary arterial blood about 70%, with venous blood about 65%. Some weeks after birth, because of this further change in pulmonary vascular resistance, you see now that there's a much bigger left to right shunt, with the pulmonary arterial oxygen saturation up to 88, and the pressure in the pulmonary artery, you see, is interesting. The systolic pressure is still the same as aortic systolic pressure, but you see the diastolic pressure has fallen. Now, this is a very important measurement because the diastolic pressure in the pulmonary artery is the best reflection of what pulmonary vascular resistance is. When the diastolic pressure is high, you will not get a big left to right shunt because pulmonary vascular resistance is still relatively high, and the fall in diastolic pressure indicates that pulmonary and right shunt associated. So that if you see a baby with a ventricular septal defect who has a large ventricular septal defect in whom the pulmonary arterial diastolic pressure is low, you know that they do not have a very high pulmonary vascular resistance. It's moderately increased, of course, but not very high. And then if pulmonary vascular resistance becomes elevated for any reason, you see now that the pulmonary arterial pressure goes way up, diastolic pressure is high, and you now get right to left shunt as well. You may still have left to right shunt, but you will get right to left shunt. Now, what happens when you have a big shunt? Well, obviously, there's a large volume load on the left ventricle. Now, this volume load is really very interesting because you see that the left ventricle has to maintain output not only of systemic blood flow, but also of the shunt. And if you think about it, it really is quite remarkable how big that load is on the left ventricle. So that if the shunt is half of left ventricular output, the left ventricle has to increase twofold, and pulmonary to systemic blood flow ratio will be 2:1. But if the left ventricle is shunting more, if it's shunting 3/4 of its output, the left output must be increased fourfold, and the QPQS ratio will be 4:1. So it's a huge load on the ventricle to handle that, to maintain a systemic blood flow. Now, if with the systemic blood flow may not be maintained, in which case the baby will have inadequate blood flow to the peripheral circulation. But of course, one of the things that's important is that this large volume load on the left ventricle results in an increase in the left ventricular end diastolic pressure in order to try to maintain this output from the left ventricle. So the left ventricular end diastolic pressure increases, left atrial pressure increases, pulmonary venous pressure increases, and pulmonary edema occurs. So that the manifestation of this huge load on the left ventricle is left ventricular failure and also, if severe enough, inadequate systemic blood flow. Now, one of the problems in premature infants, they have two main problems. Firstly, is pulmonary vascular resistance falls more rapidly, the reason being that they have less muscle, total muscle mass in the small pulmonary arterioles, and also they are less reactive, so that the resistance drops more rapidly. But another major problem is that in the premature heart, they are not able to tolerate an increased afterload. They cannot maintain an output as well as a mature newborn. So the result is that even with shunts where pulmonary to systemic blood flow ratio is 2:1, they already begin to get manifestations of failure and of inadequate systemic blood flow. A further problem in premature infants that makes them so prone to develop pulmonary edema is that they have a low albumin compared to the mature infant. So most premature infants are born with albumins of about 3 instead of the 5 that you see in the mature infants. And this means that when they do develop an increase in left atrial pressure, because of the low colloidal osmotic pressure in their blood, they much more rapidly develop pulmonary edema. So premature infants are very prone to develop trouble with left to right shunts. Now, the other problem in the premature infant, which is important, is that the oxygen requirements for body weight are much higher because oxygen consumption is related to body surface area. Now, a preterm infant has a much higher body surface area related to weight. So that this means that they have tremendous oxygen demands for their weight, much higher than in mature infants. So they therefore at tremendous difficulty if they get a left-to-right shunt with a VSD. Now, I bring this up because as cardiologists, we tend to forget about other factors that may be involved in causing trouble in babies. And one of the important things to remember, if you look at babies with VSD, you notice that many of them do reasonably well the first 2 to 3 months, and then at age 2 to 3 months they go into failure. And the question is why? And I think the main reason is that they have a drop in their hemoglobin concentration. As you know, the normal baby is born with a hemoglobin concentration of about 15 to 17 grams per deciliter, and by 3 months it's gone down to about 9 to 11, which means that cardiac output, in order to provide the same oxygen delivery, cardiac output has to increase by about 30% just to maintain that same oxygen delivery. So this, I think, is the reason that these babies get into trouble. And in fact, George Lister showed that in babies with VSD in heart failure, if he gave them a transfusion and increased their hemoglobin concentration, their failure improved immediately, very dramatically. Now, regarding hemoglobin concentration, another factor to take into consideration, which would work in the opposite direction, is the change in type of hemoglobin. As you know, infants are born with about 80% fetal hemoglobin at birth, and premature infants have 100% of fetal hemoglobin at birth. And because of this, they require a high output to maintain oxygen delivery to the tissues. So that here you see what happens with the F here refers to fetal hemoglobin, the M is maternal hemoglobin. But if you look at the hemoglobin concentration of fetal hemoglobin, you see the curve is rather flat at the top. So that if you go from the arterial PO2, which is about 100 after birth, down to venous PO2, which is about 40, you see that with fetal hemoglobin, there's very little oxygen delivered because of the flat shape of that curve for fetal hemoglobin. With maternal hemoglobin, or adult hemoglobin, you see that there's a much greater delivery of extraction of oxygen at the same PO2s. So that to provide the delivery of oxygen to the tissues, you need much less blood. And in fact, cardiac output goes down quite dramatically over the first few weeks. And if you take a newborn baby or newborn animal and you replace the fetal hemoglobin, do an exchange transfusion with adult hemoglobin, blood with adult hemoglobin, you find that cardiac output falls dramatically. So that you have here two competing factors. One is the total amount of hemoglobin, which has an adverse effect, and the change from fetal to adult hemoglobin would have a beneficial effect because it would reduce output. And it's the interaction between these two which is very important in determining how these babies will do after birth. Now, when you think about these babies with VSD, one has to consider what are the factors that really contribute to the development of cardiac failure. And I've mentioned hemoglobin. We mentioned, of course, pulmonary vascular resistance, but there are other factors that have to be taken into consideration. A baby who has some increased fluid in the lung develops increased respiratory rate and effort. Now, we don't think much about this, but when you measure oxygen consumption in a baby who has normal respiration and a baby who has increased respiratory effort, you find that oxygen consumption goes up by 40 to 50% with increased respiratory effort. So it's an enormous effect it has on the requirements for output, because to provide oxygen to the tissues, you need cardiac output. So the result is that these babies with respiratory distress are in real trouble. Another factor is sympathetic stimulation, because sympathetic stimulation has a dramatic effect on oxygen consumption. So oxygen consumption in these babies goes up markedly. In order to provide that oxygen to the tissues, they have to increase the output, and that, of course, creates a strain on the left ventricle. And we know also, you often see this clinically. You have a baby with a VSD who's doing moderately well. They develop infection and immediately go into severe failure. And that's again because of the fact that oxygen consumption is dramatically increased by infection, and therefore requirements for output are markedly increased. So all these factors are important to consider when you're thinking about a baby who has a VSD and what the impact of this is on the circulation. Now, we've talked before about, Dr. Sanders talked about the problem of pulmonary vascular resistance, and this is an important issue in these babies with ventricular septal defect. When there's a large VSD beyond infancy, and I say beyond infancy because the tendency for majority of ventricular septal defects is to close, so that if the VSD remains large beyond infancy, then pulmonary vascular resistance increase is a significant problem. The initial pulmonary vascular resistance, now, as I mentioned before, pulmonary vascular resistance in the normal infant drops to adult levels by about 8 to 10 weeks after birth, unless there's some factor interfering with that. It doesn't do so in infants born at altitude because of the low oxygen environment in the atmosphere. But in normal babies, it drops by 8 to 10 weeks. Now, in babies with large VSD, this does not occur. They drop their pulmonary vascular resistance, but not to normal levels. And the reason is that pulmonary hypertension, persistence of pulmonary hypertension, stimulates the muscle both to constrict and to be retained, so that the normal thinning out of these pulmonary vessels doesn't occur, so that by the time these babies are 4 to 6 months old, they still have a relatively high pulmonary vascular resistance. It does not fall to normal. And that's the immediate change, that effect that occurs. Subsequently, they develop other changes which are more permanent. But as long as they have mainly musculature, which is maintaining the pulmonary hypertension, they are really very good candidates for closing the defect and surgery which would improve the pulmonary vasculature immediately. Now, one of the things that we often try to determine if a baby has pulmonary hypertension is whether this pulmonary hypertension and if the pulmonary vascular resistance is increased is due to permanent change or due to mainly muscular contraction. And what we do often is give these babies or patients, older patients, pulmonary vasodilators to see how they react. Because if the pulmonary vascular changes are permanent due to fibrosis and other changes, you would not expect much response from pulmonary vasodilators. If they show a marked drop in resistance or pressure with pulmonary vasodilation, the likelihood is that this high pulmonary vascular resistance is mainly due to muscle presence and muscle contraction. So this is often used, and the pulmonary vasodilators that have been used over the course of time, a long time ago, it's not used anymore, was tolazoline, 100% oxygen, ATP, magnesium chloride. Now, more recently, the ones that are being used are nitric oxide inhalation or sildenafil. Now, as I mentioned earlier, when I talked about what happens with pulmonary pressure, if pulmonary arterial diastolic pressure falls, this means that pulmonary vascular resistance has fallen. And when you're looking, people do all sorts of measurements. They do catheterization and measure blood flows and calculate pulmonary vascular resistance. I can assure you that the best determinant of whether these patients have a response to pulmonary vasodilators is if pulmonary arterial diastolic pressure falls. And that is the best way of determining what the response is. Now, as I mentioned, with the increase in pulmonary vascular resistance, the left to right shunt falls, and end diastolic pressure in the left ventricle will fall, and these patients often improve. And so that in a child born at high altitude, because the pulmonary vascular resistance is maintained at a relatively high level with a large VSD, these patients often do not develop failure. And it's sort of rather disturbing because often these patients, nowadays it's not so common anymore, but often these patients were not diagnosed as having a problem because they did not have cardiac failure. And so that it's important to recognize this thing. In one study, some of these babies who were born at an altitude of about 2,000 meters in Denver were taken down to Houston, which is at sea level, and they developed cardiac failure. So it's really an important thing to recognize the effect of altitude. And now small VSDs, the pressures in the right ventricle and pulmonary artery are normal, and there's no real risk of pulmonary vascular problems in these patients. Their pulmonary arterial pressures are usually normal. Small VSDs, as I mentioned, have a high incidence of closure. It's very interesting that there's a very high incidence of closure in the fetus. In a study in Israel, they found that I think it was about 80%, 75 to 80% of VSDs that were diagnosed by ultrasound in the fetus had closed by the time these babies got to term. So that VSD in fetus is very common if you look carefully for it, but a lot of them close. And then after birth, a lot of them close, usually by 2 years, but I've seen VSDs closing in people of 16, 17 years of age. So it's an important thing to recognize that VSDs that are not large are usually no problem. And incidentally, we know now too that prophylaxis for endocarditis is not really indicated. Thank you.
And we will start at 8 p.m. and we have a guided tour to the brewery and we will taste beer and then we have dinner there. It's all in one price, it's all on the sheet here. And I give it to the ranks and if you want to see in the menu and what we are doing, it's only in German, unfortunately. But it's typically Bavarian food, you can trust us. Then just sign in this list and with Annalina's name is good, it's already there in mine and all the professors have come as well. So I just give it in this direction and then, so just so we know how many people join. And I put the diamond part and everything here so that you can have a look at the answer.
Well, so we're going to talk about the ultrasound of VSDs, and what the goal of echocardiography is to identify all of the defects in the ventricular septum, assess the chamber size and the wall thickness, estimate pulmonary arterial and right-sided pressures, and an estimation of the pressure across the VSD with the TR and PR as well, and identify additional associated lesions, quantify the magnitude of the shunt, which I showed you this morning. So VSDs, if you're talking about two-dimensional echocardiography, the better the size and the fix you can achieve on knowing what the VSD looks like is to do multiplanar approach of the ventricular septal defect. Often the ventricular septal defects, I'm sure Girish will show us, are not round defects. They may be oval, they may be semi-lunar in their shape, and the measurement of a ventricular septal defect simply by one dimension is really not a reflection of the true size of the ventricular septal defect. Doppler color flow imaging augments the other modes of Doppler and confirms the presence of VSDs, also improves the ability to detect and define the location of muscular defects, particularly in the apical and anterior or extreme posterior parts of the ventricular septum, particularly if these defects are small and multiple. So I put this slide in just because I happen to be an Andersonian by temperament. And here is the right side of the ventricular septum, and here is the left side. And what Bob Anderson did with this is he sliced it into the outlet septum, the muscular or trabecular septum, and the inlet septum. And of course, that other fourth piece, the membranous septum. And this defines where the various parts of the membranous of the ventricular septum are and where defects lie. Now, we can use that understanding to appreciate. I see Dr. Sanders uses the outlet septum as a conoventricular variety, and there are different names for these things which tend to confuse us. I like this picture because it shows that defects occur all over in the ventricular septum, especially all over. And the only ones that have a non-muscular rim are the perimembranous VSDs, the AV canal type VSDs, and the doubly committed. The muscular ventricular septal defects lying within the muscular septum all have a muscular rim. And it's also very important to understand and know where the conducting tissue lies. For the surgeon, it's very important. And so we try and locate the position of the ventricular septal defects, thereby inferring where the conducting tissue is available. So Steve Sanders started off by talking about the so-called aneurysm of the membranous septum, or tricuspid tissue tags. This is a specimen I found in a collection at Brompton Hospital marked calcific aortic stenosis in an adult. And indeed, that was what this patient had. You can see the tremendous left ventricular hypertrophy. What you can also see is that there are tendinous cords on this side of the tricuspid valve, and that this is a so-called aneurysm of the membranous septum or tricuspid tissue tagging. And here are some examples of that by ultrasound. This is a subcostal coronal view. This is a sort of a parasternal apical view. And you can see the jet in relationship to the septal leaflet of the tricuspid valve. And we can also measure what the pressure drop is across that ventricular septal defect. And so what's important about this is that there's a much higher incidence of spontaneous closure with this so-called aneurysm of the membranous septum than without. And when we talk about closure, we talk about not only closure, direct closure, but in the diminution of the size of the shunt that occurs here. And so this is from our 1984 paper on the subject, where we found spontaneous closure with an aneurysm occurred in 11%, became smaller in 33%, was unchanged in 29%, and had a very low incidence of Eisenmengers. The only difference in this situation was in the patients with Down syndrome. This clearly does not apply. They have a much higher incidence of persistence and a much higher incidence of developing pulmonary vascular disease. Without ventricular septal aneurysm, the closure rates were proportionately lower or became smaller in a much lower percentage of cases. And in the old days, where we were much more specific about sending patients to surgery, they had a much higher incidence of being referred for surgery. So I'll show you a couple more of these defects. Here's the tricuspid aneurysm or tricuspid tissue tagging. And you can see that this tissue, as Dr. Sanders showed us very beautifully on his pathological examples, looks very large over here, but the tricuspid valve walls off the shunt, and the shunt is really only occurring at the lower rim of the defect along the area where the tendinous cords are inserted onto the ventricular septum. Here's another example of the same, and again you can see that the defects that are aligned through this ventricular septal defect in the subcostal oblique view, here's the tricuspid valve, this is left ventricular outflow tract, are occurring not only at one place, but occurring at two places around the junction of where the tricuspid valve is related to the ventricular septum. Okay, and that can occur with a number of other lesions. Here's a patient with an isolated cleft in the mitral valve, also associated with an aneurysm as well over here. In short axis, I've simulated this. Here is the tricuspid lesion. Note the quite eccentric position of this ventricular jet here undergoing a Coanda effect and adhering to the anterior leaflet of the tricuspid valve. Here is the same heart that I stuck back together with crazy glue and cut in a simulation of a parasternal short axis view. And here is this so-called aneurysm of the membranous septum and so-called equivalent view. We can see this transesophageally as well. Obviously, many of these patients were going to surgery. Note also the distortion of the anterior leaflet of this valve, which is one of the things that we found sometimes goes on and develops such distortion that there is a development of aortic regurgitation, as the leaflet tends to act as an obturator for the ventricular septal defect. Again, as Dr. Sanders had shown, here is a so-called tricuspid tissue tagging. You can see endothelial overgrowth. This is looking at it from the right ventricle. Here's tricuspid valve. Here's pulmonary valve. And you can see that there is tissue developed in this VSD. Here is the VSD. And once again, there is, in addition, the development of a subaortic membrane, as you can see here on this echocardiogram as well. Small amount of AV valve regurg, small leaflet there, and a degree of development of a true subaortic defect. So certainly pathological confirmation of what was observed echocardiographically. And here is such a lesion at autopsy, as well as surgery. The tricuspid valve has been moved apart, and here is actually an endothelial overgrowth that is occurring around the rim of the ventricular septal defect. There's also a cleft in the mitral valve here. Now, muscular VSDs, here's an anterior muscular ventricular septal defect. You can see these things pretty easily. They are, I think, one of the easiest things to see with Doppler color flow. You can see that there's muscle on both sides of this rim, as there is here on this autopsy example as well. And in short axis, depends how you slice the heart, echocardiographically and pathologically. And here is an example. And you can see very beautifully here a clear feature of a ventricular septal defect on Doppler color flow, and that's the development of Pisa. This is the kind of ventricular septal defect that may be very difficult to image because of its small size, and is really much easier to do by means of Doppler color flow technology. Traumatic ventricular septal defect. This is from a child that underwent a septal rupture at the time of a motor vehicle accident. Here is the ventricular septum. Here is a dehiscence of the ventricular septum from the right to the left ventricular aspect. I'll put this into play in a number of planes here. And you can see this, this dehiscence here with this right ventricular outflow aspect here, the left ventricular inflow aspect here, and in the four-chamber view taken at the time just prior to surgical closure, where I took these other pictures, you can see the ventricular septal defect, and it's pleated in layers and closed quite effectively. Muscular ventricular septal defects, as we know, can occur all over in the ventricular septum. Here's an echocardiographic cut. Here's a VSD associated with a Taussig Bing malformation, and you can see the ventricular septal defect up here, but notice an apical muscular VSD below here, and another large defect from the right and the left ventricular aspect here. And here are some examples of such. And the one adage that I've used as terms of ventricular septal defects in the muscular septum, when you find one, look for another. If you find two, look for another, and so on and so forth, because they frequently multiple. And I think you can see here one defect here and one defect here, as though in the long axis you only see one defect in this patient. Here's a patient with isolated spongy myocardium, and these patients are likely to have Swiss cheese type of ventricular septal defects. And indeed, I think you can see a number of muscular defects here, as well as marked trabeculation of the left ventricle. In fact, there's also a membranous defect up here. We elected to band this child so that the septum would actually mature up before a septal patch was placed on this patient. Here's a muscular outlet defect just underneath the aorta here. Very small defect. And there's the long axis view showing the same. There's a little pulmonary insufficiency here, marking the position of the outlet septum here, going from the left ventricular outlets to the right ventricular outlet septum, but surrounded entirely by muscle. Device closure, Steve Sanders mentioned, this is a sort of a quickie of a patient that we did with a device closure, and you can see in the sequence of events, I'll go over them once again for you. First of all, we see the VSD, then you see the device put across the tricuspid valve through the muscular defect. It aligned up quite reasonably. Now the device is released. It sits in a reasonable position and is not associated with but a trivial leak at the end of the procedure. Ventricular septal defects in the membranous septum have been closed. The aneurysms have been closed with devices quite successfully using the muscular device closure. And here, courtesy of Ziad Hijazi, is an example of an aneurysm here. And there's the shunt. And here comes the wire across the VSD from the right side, from the left side into the right. And then the device is placed using a combination of angiography and echocardiographically. And here's the device in the appropriate place. And then you see the wire, and it's subsequently released. Here's the angiographic counterpoint. Here's the TEE probe. And eventually, to speed you and save you the time, let's just show you what it looks like when it's closed. And there's the device. So a muscular device placed in a aneurysm. Now let's talk a little bit about the supracrystal VSD, or doubly committed and subarterial ventricular septal defects. Here's an echocardiographic slice of a patient with such a lesion, and here's the aortic cusp, and here's the pulmonary cusp. And just as Steve showed you, there is no outlet septum between the two. And again, in this echocardiographic cut here, you can see aortic valve and pulmonary valve. This is a subcostal sagittal, so this is front and back, top and bottom. And here's the VSD underneath both of those structures. Okay, and of course you can look at that with a variety of different planes as we have here. The defect is situated more towards the outlet septum than the membranous septum, associated with pulmonary and aortic insufficiency. Here in the long axis we see pulmonary artery and aorta. There's the crest of the muscular septum. There's no intervening outlet septum between the pulmonary valves. And here, just as Steve Sanders had shown you, but I put together in one single specimen, here is a perimembranous VSD, which is related to the right coronary cusp and the non-coronary cusp. And here, on the other side of the right coronary cusp, is the supracrystal defect. And so, when we look at this in a map view, perimembranous VSDs occur here next to the inlet septum. And if this is the face of the clock, this is about 10:30, okay? And the outlet defects occur at about 2:30 over here. And the difference between these two is simply the length of this right coronary cusp. This situated at the junction between the right and non-coronary cusp, and this defect situated between the left and the right coronary cusps over here. And needless to say, the septum is aligned in a vertical direction, so this is an inferior defect and this is a superior defect. And of course, this is very important for our surgical colleagues, not that they worry that much about what we tell them anyway, but this is the kind of lesion where you can fix through the tricuspid valve, and this one is best repaired by the subarterial route. And note here, between the right and the left coronary cusp, you also see the same cusp with the commissures in the pulmonary artery. So about 2:30 and 10:30 is the difference between these various lesions. Now, one of the problems with this is that with all types of ventricular septal defects is that the cusp and the whole sinus of Valsalva, particularly with the supracrystal type of ventricular septal defect, tends to herniate through the defect. And when that happens, you get aortic regurgitation. And this is a study which we did in San Francisco and looked at the presence of cusp herniation, as we could identify it echocardiographically, over a cross-sectional group of patients. And we saw that this preceded, but almost perfectly paralleled, the detection of aortic insufficiency in the Doppler color flow era. So certainly cusp herniation, I think, is an ominous sign of aortic insufficiency. And here is a long axis view showing marked herniation, almost, in fact, a sinus of Valsalva aneurysm. And interestingly enough, sinus of Valsalva aneurysms are most commonly observed in the right coronary cusp, and perhaps on some way related to so-called closure of this defect. And when this defect herniates like this, then it makes the ventricular septal defect look very small. Except when the surgeon lifts up the aortic cusp, it's a huge VSD. So that's a very important point that you can identify echocardiographically. Now, Steve also showed us some beautiful examples of posterior malalignment. One of the problems that we have with posterior malalignment is that it's very difficult to actually observe three-dimensionally in a two-dimensional example. So here are some echocardiographic cuts, and what we see in this kind of defect, which is almost invariably associated either with coarctation of the aorta or aortic arch interruption. You see the posterior deviation of the outlet septum here in a four-chamber cut, here in a subcostal cut, and here by high resolution parasternal long axis, as well as a parasternal short axis with the septum deviated posteriorly into the left ventricular outflow tract. If you didn't like that picture, I have a few others. Now, confluent VSDs, these are the big VSDs. Unfortunately, this was a child who, following Dr. Rudolph's natural history study, never really developed signs of heart failure, but developed progressive hypertension, pulmonary hypertension, and presented to us with this large confluent ventricular septal defect, but unfortunately with pulmonary vascular disease. And here's a contrast injection from the right side of the body, and you can see massive right to left shunting. Additionally, you can also notice that the patient's got a little bit of mitral regurgitation as well, but an intact atrial septum. So a very unfortunate case, okay? Now, VSDs of the AV canal type, I think Stephen did show some of these examples. I've seen somewhat less than 20 of these lesions. I learned that from Dr. Nadis, who used to say when he'd seen one lesion that he'd seen somewhat less than 100. But the thing that's interesting over here is that in some way this must be a form thrust of an AV canal defect. And here is the cleft in the anterior mitral valve with the tendinous cord attached to the crest of the septum. Here's the VSD extending into the inlet septum here, posterior, just right next to the coronary sinus. And in most of these patients, they also have Down syndrome. So clearly there are some metal behind all of these things that are common lesions that make them a problem. Now, the importance of realizing for the surgeon that this is not a perimembranous VSD is that the repair of this lesion is much more appropriately directed through a similar approach for an AV canal, where the lesion in the mitral valve is repaired through a transatrial approach, and the VSD is repaired similar to that in an AV canal. Okay, and here again is the tricuspid nature of the left AV valve in this condition. It's not you can see there's no ostium primum ASD in this lesion at all. Okay, now what about the Doppler assessment? Well, we found Doppler is quite valuable. It's not the be-all and end-all, but you should compare the peak velocity across the pulmonary valve with also what's happening at the atrioventricular valve level. And here you can see a somewhat higher transatrioventricular velocity than the tricuspid regurgitant velocity, and also some elevation in pulmonary artery pressure. The other thing about VSDs is they shunt in systole, but when you get small VSDs, as I'm showing you over here, you can see that the diastolic shunt, that this VSD is shunting a lot in diastole, and then as systole begins, there's a short acceleration in the isovolumic period, and then there's very little until the onset of diastole again. So this is a diastolic left to right shunt. Okay. Now, I mentioned this before. This is just our method of calculating the pulmonary systemic blood flow. So not only do we, with the echo, provide an assessment of size, location, pressures, but we can also measure crudely the pulmonary systemic flow ratio. And let me remind you that the pulmonary systemic flow ratio is a crude measurement anyway. I mentioned this morning that we did it by taking a ratio of the dimension of the pulmonary artery over the aorta and square that difference, and then multiply it by the difference between the pulmonary and the aortic peak velocities and get a QP-QS ratio that way. So we provide those information. The only thing we really don't have is pulmonary vascular disease. So I think I've managed to stay within my time, and I thank you for your attention. Excuse me.
All right, so I'm going to be talking about 3D echocardiography for ventricular septal defects. And my goal is to not try to tell you that this modality is going to be perfect for every kind of VSD. It isn't. For example, uncomplicated small membranous or perimembranous VSDs, it's not really going to help a whole lot with that. But I'm going to show you some examples of situations where I think it can add a lot. Now, one of the things that people find, we talked about this earlier, and I'm going to keep hammering these concepts back because they are fundamentally new concepts for 2D echo people. So I'm going to start out by just reminding everybody how we go about getting en face views of the ventricular septum. So when Dr. Sanders showed you pathology specimens to show VSDs, he retracted the free walls of the ventricles, right? There's no other way for him to show specimen of a VSD. So in all of the specimens that he showed, the free walls were out. So we're going to do the same kind of a thing here. This is a normal heart, just to remind you of what we did before. So septal structures remain in place, and then we kind of expand the heart out that way, and that's the en face view of the ventricular septum. That's the inferior interventricular groove, if you will. And that's sort of the anterior interventricular groove, aortic valve over there. And then you can see the same thing from the right side as well. Okay, now we'll go on to some muscular VSDs. So the first one here is this is sort of an off-axis cut. Okay, it was supposed to be an apical 4-chamber cut, but it wasn't really particularly well cut. So here's what that looks like. Looks familiar, right? 2D echo. There's your muscular VSD. And so the straight question here is, how big is this VSD, right? So you say, well, from there to there, that's the size of the VSD. It makes sense, I suppose. So what we're going to do now is we're going to put in what's called a crop plane. So instead of always cutting in from the sides, you can also put in planes to cut off walls of the heart that are not at the X, Y, and Z planes. So this is what we call an anatomic crop plane. And I'm going to bring that in here. You see that? So I'm cutting off the walls of the heart now from the left side. And sometimes, if your hand slips like this, then you can always go back, which is an advantage compared to what the surgeons have to deal with. So I like that, so I'm going to retain that. And then I'm going to bring the same crop plane out on this side, right side, and then I'll cut that side off as well. One of the things to remember with 3D echo is when you do these maneuvers, you are not going to be improving frame rate or line density or anything like that. All you're doing is you're just going down to the region of interest. That's all. Okay, so now we'll retain that, and now I'm going to turn this image around to look at it from the left side. So this looks terrible, right? Why did we do this cropping? It's really not helping at all. But we'll expand it that way and expand it this way. And now we're looking at the LV side of the ventricular septum. That's the inferior interventricular groove. That's anterior over there. Where's the VSD? How about this thing here? So if you look at it from above, you still can't see it. But if you look from below, there it is. All of that is a VSD. Okay. So from an apical 4-chamber view, 2D echo, we got this kind of a concept of how big the VSD was. And when you look at it from the right side, you look at it from above down, and there it is. So this is a big slit-like VSD that is actually pointing from right to left. It's like a tunnel. It points from above. You know, it opens higher up on the ventricular septum on the right side and lower down on the septum on the left side. So it's almost like somebody took out a little wedge from the ventricular septum in this situation here. So these are views that I think they're kind of useful because they tell the surgeon what to expect and where they're going to see this thing. So this is the tricuspid valve up here. We're not seeing it completely because we've cut away a lot of the structures, but that's this is not going to be difficult for the surgeon to see. Of course, it's not difficult once you cut away all of the trabeculations like we've done, but that's probably the moderator band there. So this is sort of above the moderator band, this hole. The next one I'm going to show you is one that's below the moderator band, just for a little bit of variety. So these are some standard things that I like to do with our 3D images. They always come up in this particular software, they always come up with about 50% compression and 50% gain, and those are settings that may work well for adult patients, adult hearts. They really don't work very well for pediatric hearts. And so for kid hearts, I tend to drop the gain down substantially, and I also tend to drop the compression down. So once again, you can see by 2D that this is going to be below the moderator band. Again, the question of how big is this hole? And I forgot to show you what the 2D would look like here. It would kind of look like something like that. That's a gap over there, all right? So we're going to do the same thing again, and we're going to expand out the sides of the heart here, and you're going to see this hole over here. Okay, it actually has some extension back down towards the apex. So these are some really crazy VSDs, in terms of the way they extend. And the 2D echocardiographer can absolutely figure these things out by sweeping and all of that. But this way, the big advantage is, I think, that you can actually communicate the image to your surgeon quite nicely. So now here we are looking at the same VSD from the RV aspect, right? So one of the challenges with this modality right now is that you have to keep in mind from where you're looking at the heart, because for example, you lose a lot of the standard landmarks when you do the dissections or when you do 3D cropping. That's one of the things that we've been sort of talking about with the manufacturers, is the ability to put labels on there in 3D space so that when you rotate the picture around, your orientation stays, because people frequently get what we call lost in space. So for example, this is the way that the image started. So if I take this image and I twist it around because I've kind of forgotten what to do, then if I hit 3D home, it spins the image back to the way it was before. Okay, or if I decide to crop into this image and do, and then I get kind of carried away and I make it into a small piece of nonsense like that, then if I hit reset crop, at one shot it'll give me back everything. So then I don't have to try to retrace my steps for all of that. This is making sense in terms of the ventricular septum. Remember that we're not yet looking at the outlet septum. You can't see the outlet septum from an apical 4-chamber acquisition because it curves around to the front. If we tried to do that, we would lose out on the inlet septum, or we would need a really big transducer for a little kid. So that doesn't quite work well. Next one I'm going to show you is just to show you the concept of how a canal VSD looks. So this is, we're going to start out by just showing you something that is very obviously a canal, like that. It's obvious, right? So how big is the hole? It's big. You don't really need measurements to tell you that. But here the question again is, let's look at the septal structures en face and try to understand the VSD in this sort of new en face kind of a presentation. So to see the septal structures, we have to cut off the free walls. And if all of this sounds monotonous, it's because that's the idea. I want to show you that we are going to be doing pretty much the same things every single time to answer the relevant questions. So now this time we're going to look at it from the right side. So I now give back the front of the heart and give back the back of the heart. And that's the VSD there. So all of this is the VSD. This is the superior bridging leaflet. That's the inferior bridging leaflet. All of that is a VSD. So this extends to the membranous septum. It extends way back to the inlet. It is a canal. What does this look like from the left side? Well, just turn it around and show it from the left side. So there it is again. Okay. And by the way, that's a pulmonary valve over there. This time the cut is a slightly more anterior cut because it's a smaller kid. So we're able to get more of the heart in with the transducer. One of the things you'll notice here, you'll see a lot of black spots here, and people keep wondering if that's dropout. And you can do some things to try to improve the answer to that. So for example, if you bump up your gain, which you can do after the fact here, if you bump up your gain and your pictures look like this, then you're trying to look through muddy water. It's very, very murky. You should not see contrast inside the chambers, inside the cavities. That's too much gain. And if you make it look like a 2D picture, then that's too little gain. So your gain has to be kind of like the Goldilocks thing, just right in the middle somewhere. And if you bump up your gain more from there, then you start to get a sense for what fills up. The real VSD will not fill up with signal. The false dropout will. So that's the same thing again, looking at it from the right side. So large VSD extending below the superior bridging leaflet and also below the inferior bridging leaflet. The next one I'm going to show you is, this is a sort of a complex conotruncal malformation, but I just wanted to give you an example of anatomic detail that you can see with VSDs. So this is parasternal long axis live 3D image, LA, LV, and the aorta is coming off over there, all right? So the question is, where's the VSD? Here it looks like the ventricular septum is intact. So if you turn this, grab hold of this thing and turn it, then you start to see there's the VSD. So that's kind of interesting. It's slightly more rightwards than what you would expect it to be. And then the question is, well, what does it look like from, clearly this aorta comes off the RV, there's no doubt about that. What does it look like from the right side? So you can turn this thing around, and now we're looking from the right side. So this is the right atrium. This is the anterior leaflet of the sort of the tricuspid valve. And just by the way, so septal leaflet is over here. We've cut off the free walls again. We're looking only at septal structures. And this is the papillary muscle of the conus of the tricuspid valve attaching there. This leaflet here is the aortic valve leaflet. And when you tilt this thing down, you see there's the VSD. So the VSD is in the Y of septal band, if you will. Papillary muscle of the conus inserts between the two limbs of the Y of the septal band, and that's your VSD. So I got this image at live 3D, and I was very happy, showed our surgeon, and I said, look, this is what it's going to look to you when you go down from the right atrium. And he said, why would I go down from the right atrium? I'm going to be doing a ventriculotomy to put in a homograft. So show it to me from my view. So his view or her view is, so here we go, LA, LV, there's the aortic valve. So he wants to do a ventriculotomy here. So we can do a virtual ventriculotomy now. Cut off the front of the heart and turn this thing around, and that's what it's going to look like. So there's the aortic valve. This is a fold that this patient has. It's like a ventricular infundibular fold, like a muscle ridge kind of thing. And this is that papillary muscle of the conus. And that blue stuff that you see there, that's the VSD. So it's bisected by this papillary muscle into an posterior inferior part and an anterior superior part. Okay? So it's live imaging. You got a pretty decent frame rate of around 30. So this is this I thought might be kind of helpful. Norman showed you a membranous VSD device. I thought I would show you the same thing by 3D. Now this is a parasternal long axis view that's tilted towards the tricuspid valve, all right, and it doesn't look recognizable from here. I'm not trying to show you that, but if you look at it from the right side, that's the device right there. Once again, anterior leaflet of the tricuspid valve, septal and inferior leaflets over there. That would be the membranous septum at the anteroseptal commissure. And just by the way, see how that thing pokes out there, the screw. This is after it's been deployed. I mean, this is in follow-up. So when you see how big the profile of this VSD device is, it makes some sense that these are not really being put in anymore, incidence of heart block and so on and so forth. And the last one I'm going to show you is as an anterior malalignment VSD. This was obtained a while ago with an old machine, but so I have to kind of change the colors on it. So just by the way that 3D echo really got people frustrated early on was because the images looked like this. They looked gray, and you couldn't tell what was in front and what was behind. So we were still stuck with the two-dimensional display that looked very gray, and you couldn't appreciate anything. And there's no money in the system now, so nobody's going to pay $50,000 for a three-dimensional display anymore, except to watch TV or at home or something. So one of the things that we talked about with the engineers then was give us depth perception. And so what we've got here is this sort of orange color, and I'll explain that to you in just a moment. So the orange is for the front, and blue is for things that are in the far field over there in the back. You see. And this is a dynamic coloration, so that the structures that are in the back here are blue now, and the ones in front are orange. And when you turn it this way, these structures remain kind of orange relative to those structures. So whatever is in the far field will always look blue to you. It's sort of a cheating way that the engineers developed. Once again, this is a live image, and and the first thing is going to be people get nervous about it and start to think that they are going to basically lose their perspective and kind of start to see unusual things. But this is the septal band here, anterior superior limb, posterior inferior limb. There's the tricuspid valve. That's the aortic valve. This is the Y of septal band. This is the VSD inside the limbs of the septal band. This is anterior superior malalignment of the outlet septum. That's the pulmonary outflow tract there, and this is the aortic valve over here. Okay. You can turn this and look at it from the left side. So this is the mitral valve, the aortic valve, and the VSD again over there. And finally you can actually look at this from inside the aortic valve this way to figure out this whole question of 50% override or how much override. And I think this shows the difficulty of trying to decide 50% versus not. So this is an unusual view. What we're doing is we've transected the aorta and we're looking down the aorta. This is the aortic valve here. That blue thing there in the bottom of the picture in the far field is the crest of the ventricular septum. So this is why I kind of don't like the 50% rule, because where do you take it from? This side of the septum, that side, the middle, which phase of the cardiac cycle, etc., etc. So I'm sure Norm is going to give me a lot of trouble about saying that, but you get the general idea of how we kind of decide various things. So that's my presentation on VSDs.
While I'm setting up, I don't have echo clips to show. Do you want to open some windows and get some air? I think that would be helpful, especially since the subject matter of mine tends to... No, I'm just looking for the that project well enough? Can you see? Okay. Right. Thank you. So just to talk about some of the functional aspects, I think probably the most important things were said by Dr. Rudolph in terms of the physiology. There are extremely few studies looking at VSD function. There's nothing on strain. I'm going to show you a little bit of data in the next 10 minutes on what I have. So there's very little data on this, but in preparing this, I came across a few interesting observations. So as you heard, this is my only echo image. Don't worry, Steve, it's only one. All I wanted to say is what you've seen repeatedly, that a VSD, a large VSD with a large left to right shunt creates a volume load on the left ventricle, as you've heard, with left atrial and left ventricular dilatation. Now, if you look at blood flow and at tissue flow, let's see then if we look at the blood velocities, the E wave here is determined or is related predominantly to the pressure difference between the left atrium and the left ventricle, whereas the tissue Doppler velocity is related more to the volume change in the ventricle. So if you're looking at a large E wave, there's likely to be an elevated pressure gradient between the left atrium and the left ventricle. If you're looking at the E prime wave, that's related more to the volume change between systole and diastole. Some of the data that's out there was from Ben Idem when tissue Doppler started being used, and he was looking at the effects of various loading conditions in congenital heart disease on tissue velocities. And I'll show you the velocities in the next slide, but I've just highlighted the VSD data over here in just under 100 patients, 94 and 94 control subjects. You can see that the end diastolic dimension is not different between controls and patients. So I think you have to remember that when we look at the velocities. The function was normal in both, and also the E-A ratio was actually not increased in the VSD patients compared with controls. In fact, it was a bit lower. This is tissue velocities over here, and if you look at all VSD subjects, you see that they're very similar to controls. So these ventricles weren't, on average, weren't very large. The velocities are not very different from controls. The E to E prime ratio, which I told you reflects filling pressures if you have relaxation abnormalities, and that's related to what I told you in the previous slides, where one is related more to pressure, one is related more to volume, and you will correct for that. We'll go into that when we talk a bit about diastolic function, but they mildly elevated as you would expect. Now, if you compare small VSDs to moderate to large VSDs, you can see actually lower tissue velocities in the large VSDs versus controls. It's not significant, but versus controls and versus a small VSD. So that may be related then to the ventricular enlargement and the adaptation that I was talking about before, because that's not really intuitive. But remember that what I also told you about chronic versus acute changes, these are chronic patients, so there's ventricular adaptation. Now I'm going to talk about this study, which uses pressure volume loops. So before I do that, I thought I would use this opportunity just to talk about pressure volume loops for those that haven't seen this in a while or don't think about this. So this is a pressure volume loop, which has been quite useful in invasive cardiology when measured with catheters placed inside the heart to determine function. And you record volume and pressure simultaneously, and you have certain phases of the cardiac cycle. And it's a circle, so you can start wherever you want. Here's end systole. At end systole, there's a rapid decrease in pressure without a change in volume. That's isovolemic relaxation. At the point where the pressure goes under the atrial pressure, the atrioventricular valve will open. The ventricle will start to fill in diastole. Here's the end diastolic point, at which point the heart starts to contract in the isovolemic period, where you have a rapid increase in pressure without a change in volume. Both the mitral and aortic valves, or the tricuspid and pulmonary valves, are still closed. And then, as I said to you, after the ventricle has built up sufficient force to open up the aortic valve opens here, and there's ejection with some elevation in pressure and a decrease in the volume. So this is the stroke volume, and there are many parameters relating to ventricular work and function that you can take from this. The parameter that I want you to take from this for the next slide is this parameter here. If you create a family of these pressure volume loops by varying the loading conditions, such as occluding the IVC or giving a saline bolus, changing the loading conditions, you'll get a family of these loops, and then you can draw a line that connects this end systolic pressure volume point over there. The slope of this line, you can see, is relatively constant despite the change in the loading conditions, and this is the end systolic pressure volume relationship. The slope of this line is one of the best measures that we have of ventricular contractility. So this is thought to be a reference or a gold standard measure when you compare contractility. From this relationship over here, you can get what Dr. Rudolph talked about in one of the previous lectures, which is ventricular compliance, so the change in volume for the change in pressure. And you can see that at a certain volume, if you're stiffer or less distensible, you're going to have increased pressure. If you're more distensible, you'll have less pressure for the same volume. So those are the kind of things you can get from pressure volume loops. So when I was looking for material on strain, which I didn't find, I came across quite an interesting study, and I'll tell you why I found it interesting. Because as pediatric cardiologists today, we tend to relate to ventricular septal defects as relatively benign lesions where there isn't a change in contractility, certainly, and patients do well, and if they have heart failure, etc., it's related to volume load, although I think that Dr. Rudolph's comments were very interesting in that regard. But this study by Michael Gewitz in 1995 looked at patients with open VSDs with and without congestive heart failure, and they used echo to really look at diameter as a surrogate for volume and put in pressure catheters at cath to get the pressure, and then related the change in diameter to the change in pressure, just like I showed you the volume pressure loop beforehand. And what they found was that patients who had clinical congestive heart failure had a less steep slope of this pressure-volume relationship compared to patients without congestive heart failure. And remember, I said that the slope of this line is a measure of contractility, not dependent on loading. So what this would suggest is that patients with congestive heart failure have decreased contractility, if you believe this measure. These ventricles were also less compliant, and they had higher pressures for the same diameter. So I thought that was interesting because that's not the way we relate today, at least me in my clinical thinking. That wasn't the training I received on VSDs. Some of the places where we might think about those kind of changes are acutely after the operation in the ICU. And this is a study with a smaller number of patients that looked at ASD, VSD, and AVSD. So there's 16 VSD patients. They were in the ICU for between 3 and 4 days. And they looked at the time they were ventilated. And they also took troponin, supposedly as a measure of myocardial injury, although you could argue that measure. And these people looked at tissue velocities. And you can see this is the preoperative tissue velocities. And again, the VSD patients had lower tissue velocities, which is surprising. I told you tissue velocities are related to the volume change. These are patients who are undergoing surgery. Supposedly, they have large volumes. So this is counterintuitive to me. And when you look at isovolemic acceleration, which has been proposed as a relatively load-independent measure that correlates with contractility, their IVA is also very low. So perhaps they really do have decreased contractility, but it's low not only in the LV, also in the RV. So I found this pretty interesting, although it's a small group of patients. But this study was really interested in post-operative changes and velocities, and you can see that there's a decrease in velocities and in IVA after surgery. And what's interesting is that this correlated with the amount of troponin, so perhaps the myocardial injury, and it also correlated, not very strongly, but it's a small group, with the ventilation time. We don't use this currently in the ICU. We don't measure tissue Doppler and then, and then kind of predict how long patients are going to be on the ventilator, but this is a study where it correlated. I showed you this work by Michael Chung in regards to ASDs with the force-frequency relationship using isovolemic acceleration. You can see that in VSDs, there is a decrease. There's a blunted force-frequency relationship after surgery, perhaps explaining those changes that I just showed you versus ASD where there wasn't much change. Now, I'm going to switch gears for a second. This has nothing to do with tissue Doppler or strain, but I found this interesting in light of what I just told you about ventricular function. This is a study from Thomas Moller and Henrik Brun, who both of them spent a year in Toronto doing fellowships, and they're back in Norway now. And this was a study they did in Norway relatively recently. And they were looking at the response of patients with shunt lesions. They took patients and they exercised them. And they divided those patients into two groups. Those that at peak exercise developed a right ventricular systolic pressure of greater than 50, so-called abnormal response. And those patients with the same lesions, ASD and VSD, that developed a right ventricular systolic pressure, and this is using the TR jet to assess right ventricular systolic pressure of less than 50. And it's interesting that there wasn't much difference between the open VSD and controls, but you can see there are quite a few patients with closed VSDs that have elevated right ventricular systolic pressure at peak exercise. These were children that on average were repaired, the age of the patients is between around 13 and 25 years. They're repaired at around 5 years, so relatively late compared to recent standards that may affect this, but that's quite surprising. ASD was similar. If you look in terms of their ventricular function, at their right ventricular function, did this impact right ventricular function? And you use the tricuspid annular systolic excursion by M-mode or the tissue velocity, you can see that versus the controls, here's the controls, there was a decrease, especially in this closed VSD group. So this seems to be affecting right ventricular longitudinal performance, and there was also a difference in the closed ASD group. And if this is clinically significant or not, there seems to be, because this is the oxygen consumption during peak exercise, and this is a Z-score, so it's related to the size of the child or the body surface index. And you can see that these closed VSDs had especially reduced exercise performance, which was true for all groups, in fact. So again, we close VSDs, and we think that these patients have very good outcomes, but these studies suggest that there are abnormalities around. This is the last slide, but some patients develop right bundle branch block after surgical closure of a VSD, and you could say, does the abnormal electrical activation affect ventricular function? Again, a small study, 14 patients with and 12 patients without right bundle branch block, and in this study, there weren't any differences, at least in tissue velocities, between the two groups. So that's where I'm going to end regarding VSD. I just owe you an answer from the previous lecture on the age of patients with ASD closure who had increased apical strain, and the age there was around 39, and they got ASD, and they underwent, the age range was very wide, the spread was very wide, but they got their ASDs closed in the closed group at around 33 years of age, again with a wide spread, so relatively late. Okay, thank you. Do you want to have discussion, Norman? So I suggest that the faculty come up here so that people can see instead of twisting necks around.
That's a lovely view of Toronto.
Yes, you can see the Alps in the background. We've done wonders to make mountains there. While people are thinking of questions, I had one question because I've encountered this a few times in clinical practice. I seem to see a lot of children with VSDs, usually restrictive VSDs, with right ventricular muscle bundles, or so-called double chamber RV, if you will, with quite significant gradients. And then there's the VSD jet, and there might be a tricuspid regurgitation jet somewhere in the vicinity. And beyond the 2D image, it's quite difficult to assess the outflow gradient in those children to decide if this is significant in terms of the gradient. Any suggestions or comments on that? Because none of you brought up this issue, and I don't remember seeing it so commonly as a fellow at Stanford, but in Toronto we seem to see a lot of right ventricular muscle bundles with VSDs.
I think we do. I just didn't put it in the VSD talk.
Okay.
But we see a fair number of them.
His name now.
Shirani.
No. Pierre Wong. Pierre Wong. Pierre Wong.
I will try to wrong thing. They noticed that they could actually look at the displacement of where the muscle bundle was relative to tricuspid size.
Actually, it was in relationship to where the pulmonary valve. You could measure the distance between the pulmonary cusp and the takeoff of the moderator band from the septum. And this was shortened and it was in a...
normalized it to tricuspid valve angles.
No.
Was it not?
No.
Anyway, I think the Doppler gradient is often very difficult to
Yeah.
assess because you can't separate it from a restricted
Right.
VSD jet
Right.
coming across.
That's
Right.
I think the one area where I've made a mistake and learned from it, but this exact situation has been, where people think that, or I thought that, that the VSD jet would act like a race car, that it would shoot in a subcostal short axis view, it would shoot towards you and then speed up around the bend and then accelerate going out the outflow tract. And so I attributed the high velocity going out to the VSD jet itself, and in reality there were two different jets, and it was really a matter of identifying, recognizing substrate. If you don't recognize this, this is not something that the surgeon is going to go after typically, and if they don't, then they're going to come after you after the operation.
Well, the patient will, because they're going to have to go back to the operating room, yeah.
They're going to unmask something not very pleasant.
Yeah.
You're going to convert a ventricle that that maybe had a restricted VSD coming into it into suddenly a sort of a pressure loaded ventricle that's just seen a bypass.
But the other clues, I mean, right ventricular hypertrophy is much more common in that group, and you can recognize that. But I think they're looking at the parietal and visceral bands of the crista, or what helps you make that diagnosis.
And I think that's right. A subxiphoid short axis view is really ideal for this. And with color flow, you can see a second jet through the outflow tract as opposed to the jet coming usually more perpendicular to your view through the ventricular septal defect. And the hypertrophy is important, and it's important to remember that it's differential hypertrophy. The inflow part of the ventricle is thick, but if you look at the outlet wall, the free wall of the right ventricular outflow above the muscle bundles, it's thin. So there's a big difference in the thickness of the ventricular walls from the inflow to the outflow because there's a big pressure gradient between the two.
Specimens in your collection with double train?
Almost none.
I've also got a few, but the thing that
Almost
I've
none.
noticed
I couldn't really find one when I was preparing for this.
I've got some, but what strikes me as amazing in this is, apropos what you say, is the turbulence that exists on the right ventricle makes a whole lot of callus in the right ventricle. And I wonder if you go in, when you're looking at this surgically and you look towards the infundibulum, you see all this callus. You must think that that's part of the information.
Yeah, there's increased
epithelial proliferation.
yeah,
It's sort of a contributing
right.
type of effect.
Someone had a question here.
Sorry to bring you back to ground level. I'm going to ask a more basic question. I'm fascinated by Dr. Silberman's talk on looking at the outcomes, specifically post-surgery, and you looking at a suboptimal cardiac function there. And I'm just, because we all deal with congenital heart disease, it sort of brings to mind, could this be due to the initial volume overload and the strain put on the ventricles, or is it because of an intrinsic abnormality of the cardiac itself?
But wait a minute, these patients were closed at an older age.
So
The VSDs
there were a few studies.
and the
right?
ASDs.
The studies, the pressure diameter study was unrepaired patients.
Yeah.
So those were unrepaired patients. The patients in the PICU were obviously repaired, and they were looking at immediate post-op function.
which is-
But there were also reductions in the pre-op function. But I'm wondering if Dr. Rudolph had any thoughts on that data.
But the one you said was at 5 years or so.
Yeah, no, right. But that's what stimulated my question. I just wanted to bring it up because that's not the way we think of it.
One of the challenges with interpreting studies that are done from, let's say, different parts of the world with perhaps different surgical techniques and different myocardial preservation kind of things. So, for example, if you look at VSDs that were repaired over 15 or 20 years ago, chances are, at least some of them, depending on the center, were done for ventriculotomy, right ventriculotomy, which is not typically done these days for most VSDs. And that may not be something that would really translate over.
I think that's a good
One
point.
last question.
We talked a little bit about subaortic membranes. You said talked about this. I would like to hear about comment. What is your strategy in dealing with these malformations? So, as I understand it, you see these turbulent flow in the outflow tract, and if you don't have a significant gradient or you don't have aortic regurgitation, do you just leave it, or do you go prophylactically to deal with it surgically in order to, or in the knowledge that it might be affect
Right.
further
That's true.
function
Yeah.
of the valve?
And I think it in part depends on the appearance of the membrane. I think, small little ridges probably don't amount to very much. But particularly if it's more circumferential, if it goes over onto the mitral valve, then I think one has to really consider that. The other consideration, of course, in membranes that are present or little ridges that are present with a ventricular septal defect is that these are right on the crest of the septum. And right below these is the conduction system. And so, sending a surgeon in to futz with this is not without some risk. It's possible to create heart block by resecting this little ridge. So it seems to me that unless you really think it's something significant, I probably would leave it alone. I mean, we've seen a number of these that don't really progress after VSD closure. On the other hand, there are ones that do. And I think it's not necessarily very easy beforehand to really figure out which ones are which, except if they really extend around. If this is just a small ridge just on the septum, my sense is that those are less of an issue. But if it's really more circumferential and extends over toward the mitral valve, I think these are the ones that potentially cause trouble. And I think you can also look at the Talgeba, I think, was published a nice paper looking at the shape of the left ventricular outflow tract, which can also be helpful in trying to predict which patients will really develop subaortic stenosis. The longer the intervalvular fibrosa, the more overriding of the aorta there is, the more of an angle there is between the aorta and the interventricular septum, the more likely the patient is to develop subaortic stenosis. So I think you really have to use a number of things because it's not easy. It's not obvious when you first look at this which ones might progress and which ones will. And it's not trivial to remove this thing.
Now, let me just add a little thing. I wrote a paper on the pathological appearance of this with VSDs. And surveyed all of the patients at the Brompton Hospital records when I did a postdoc there, and found, in fact, that you could see subaortic ridges develop as early as 2 weeks
Whether they were present before birth, I don't know, but we certainly could see subaortic ridges early on. And interestingly, the subaortic ridges, and this is a cross-sectional study because the specimens are one time. So we looked at them from neonates to adult on. And what was apparent, and this is the bad news, so one of your specimens showed a double ridge.
Yeah.
So the problem is that as you look at these ridges, they change their morphology. And if you look at the basement membrane, what it really is, it's a network. It's not a boundary. And at some time, in some of these patients, the fibrous tissue starts to invade through this membrane. And that's when you get this sort of candle waxing type of appearance of the left ventricular outflow tract.
Although that's
some
often...
of those patients go on. I mean, I don't know what the long-term answer is because you close the VSD. Some of them, the LV outflow tract is big enough that it isn't going to be a problem. But there's obviously going to be those patients, and I think that's a matter of clinical judgment as to when you have to go in and fix them. Whether you actually want to go in and fix them at the same time as you do the VSD repair is another issue because to dig these membranes out through a tricuspid
It's not straightforward.
It's very difficult. A better approach is to go
transaortic.
into the aorta, open the valve, and then take out the subaortic tissue there.
No.
So I think I would agree with Steve and say that on a clinical basis, unless there's absolute reason to go in and operate on those patients, that you adopt a conservative approach of repairing the VSD, but following the patient.
Yeah.
And that's really what the bottom line is, because what we aren't doing these days is we're not looking at the older adult congenital patients. And this is a progressive disease.
Yes.
And I think that's the best approach to looking at that.
I wanted to ask you, do you have any information regarding what happens to ventricular function and all the various measurements in a patient who has ventricular hypertrophy which then regresses? Does it ever go back to normal?
No, I have information on different types of ventricular hypertrophy. There's quite a bit of information. So different etiologies of hypertrophy, but not in terms of regression. So
that's the question I wonder, whether the ventricle ever really returns to normal.
that's a good question, but I don't have that information.